Good afternoon, everybody. My name is Kevin Clausen, and I'm here from Nova Southeastern University. Wanted to take a moment to introduce the other two members of the team. Dana Lewis from Swedish Medical Center, and as you probably know, is also the founder-creator of the Hicksum Tweet Chat. We also have Boris Glance, who is the CTO of mHealth. So together, the three of us are going to share with you a little bit about the journey that we're currently on in trying to answer the question about what happens when you combine the participatory research design approach, a patient engagement company, to try to conduct a mobile health study. So at the Center for Consumer Health Informatics Research, we have a couple different mHealth studies or mobile health studies going on right now. But for this particular one, we wanted to try to do something a little less conventional. And by less conventional, I'm referring specifically about the approach rather than the design or the intervention with the study itself. And so to that end, that's brought us to our current study, the Resolving Medication Issues for Non-Adherence in Diabetes, or the REMIND study. Interesting side note, interesting to me at least as an academic, there was a study in JRSM that was also run in a Ben Goldacre column that demonstrated that research papers with an acronym in them were more likely to be cited than papers without an acronym. For our particular case, we really just wanted something we could kind of quickly refer to the study and having to, instead of saying resolving medication issues for non-adherence to diabetes every single time. So that works for our purposes with that. And our goal with this particular study is we really want to try to help our patients with type 2 diabetes be in a better position to manage their disease. To do this, our strategy is to ultimately kind of try to target what's low-hanging fruit. If I used air quotes, I would use air quotes for low-hanging fruit because obviously nothing within healthcare is true low-hanging fruit. But in this particular case, we're looking at medication adherence. And so there's a lot of different factors. There's many root causes associated with medication non-adherence. What we decided to do in this particular case was limit the focus to one, and that, as you can see, is forgetfulness. We did this for a couple of reasons. One is that means there's fewer variables when we're looking at the issue itself. The other thing means that it will allow us, if we find a positive results with the intervention, that it's going to be much more scalable going forward. And we quickly decided that what we wanted to do was use a mobile-mediated intervention for trying to improve that medication non-adherence. We selected a mobile phone for two primary reasons. One is simply the ubiquity of the cell phone. You hear all these stats that there's more access to phones than toilet or clean water in the world, so there's a lot behind that, and that was half the reason. The other half of the reason is that people will stop almost anything that they're doing to check their text messages. Actually, there's a subset of people who literally will stop doing whatever they're doing to check their text messages. And because I'm an academic, I have to cite that if I'm going to say something. So 2010 Restrepo study basically found that in a group of younger folks. So we are using this text message. The text message, or SMS, is our primary means to have the intervention. And for that, we contracted a company that has a strong research track record. Memotext, they've got a really good personalized adherence solution. And more importantly for us, what that did was it allowed us to not have to deal with any of the minutia, not have to deal with monitoring those types of things, whether that be clinician, researchers, et cetera. It automates the entire process, which speaks to less work for us, which is great. And the other thing from sort of a novel approach that we wanted to do is looking at setting. So almost all of the mHealth research thus far, at least the published research in this area, you're going to see it conducted at an AmCare setting, a primary care clinic, et cetera, but really nothing's been done out of a community pharmacy, which I think is unfortunate because it doesn't take advantage of the prevalence of the community pharmacy. So there's lots of areas where you can't go a city block without seeing a Walgreens, a CVS, a Duane Reade, an independent pharmacy. So within all of those pharmacies, of course, is the pharmacist, which means this person is the most accessible healthcare professional for patients. So we really wanted to capitalize on that and build the innovation based out of a community pharmacy. In doing so, what our hope is, again, if we find positive results, This means it would be eminently scalable from a setting perspective to spread it out in the future. All right, so that's sort of the broad strokes of the study that we had gotten to and I had gotten to, but I thought that there were two really, really key missing pieces in what we've talked about thus far. The first one is that our traditional means of soliciting and eliciting patient information and collecting patient data was not a particularly good tool. It's still largely the clipboard in many cases. So I saw what Boris and mHealth had done with the University of California system, with the Athena Breast Health Network, which is this massive undertaking if you're not familiar with it. And they were doing some very, very cool and very, very engaging things with converting old style types of data intake and collection. So it seemed like it was a great fit for this particular study. The other thing that was missing was the patient voice. And as we've heard echoed quite a bit, I think in Medicine X, and rightly so, if you are planning to do anything where you're purportedly trying to partner with a person or a group or help a person or a group, but you don't include their voice, you're probably destined for failure. I love the example, I think it was a day or two ago, where someone said that they were designing health information kiosks for patients with migraines. And so the purpose of it was to answer patients' questions. So to determine what kind of questions they wanted to find out that patients would need answers to, they asked one urologist. That was it. So unsurprisingly, that particular project didn't really take off. So in this particular case, once I sort of identified that, I approached Dana. And I approached Dana for a couple of different reasons to invite her onto the project. One is because of her familiarity with diabetes, type 1 in her case, but really almost more importantly because the project needed someone who was a really strong advocate for patients and who was very self-assured. So I've been involved with a little bit of research that involves patients and some other initiatives, activities, PCORI, et cetera. And unfortunately, what I've seen in some cases is that when you take patients and thrust them into an unfamiliar role, it can be intimidating. And for those of you that have been in any type of research planning or study sessions for grant reviews, it can get pretty heated and people can get shouted down. So what I didn't want to do was introduce someone who I didn't feel was totally equipped to try to handle those challenges. In Dana's particular case, since I was aware that she had testified in front of Senate as a college sophomore, I think, to try to encourage more diabetes research, I figured she could probably handle like a handful of ivory tower folks like myself. So I approached Dana about that and was very happy that she decided to join us. So moving on to the protocol itself, we have 3 different groups in the study. The first one is the control group. Group 1 is the control group. So no text message intervention, no SMS, et cetera, no intervention of any kind, ergo they're the control group. The second group is a passive intervention group. So what happens with them is they get unidirectional messages. So they get a text a day, they don't have any voice in what the message says, how often it comes, et cetera. The third group is the active intervention group. And so by active, what I mean is there's 2 pieces to it. The first one, where we're trying to sort of adopt some of the aspects of the participatory medicine model and shared decision-making, we ask them, what do you want the message to say? We give them a voice in that. How often would you like it to come? What frequency, what time, et cetera. So we try to get that front-end piece built in where they have some investment in it. And then longitudinally throughout, the other difference is it's bidirectional. So they're expected to respond back when they get the messages and the reminders to give us and share some information about their medication-taking disposition. So we have, of course, to measure our outcomes. We have lots of different measures and validated tests and gold standard things and all that sort of stuff. I'm going to limit it to 5 in this particular case. The first one, of course, is knowledge of disease. So we're looking to get baseline information about how knowledgeable the patient is about their disease. In this particular case, we're using the aptly titled Diabetes Knowledge Test to do that. So our intent is to look at and see if this information correlates or to what extent with medication adherence. So similarly, we're going to be looking at health literacy using the REALM short form, another standard validated test for this particular pursuit, also with an eye towards seeing if any type of relationship exists between health literacy and medication adherence in this particular study. For engagement, we're going to be using the bidirectional texting primarily, longitudinally throughout. For medication adherence, we're using sort of a triangulation effect of multiple different factors, but the main sort of tool-based one or survey-based one is the Mariski medication adherence scale. And then finally, of course, tied to our primary outcome, which is going to be at 6 months. So this is a 6-month study, baseline visit, 3-month visit, and 6 months. And at 6 months, our primary outcome is going to be hemoglobin A1C. And that's where we sort of hang our hat on the clinical piece. But we're very optimistic about the rest of the information that we're collecting having pretty high utility. So I'm very happy to announce that we are, in fact, recruiting for this study. Like all research, we ran into some obstacles that we had to navigate. And probably the most daunting one was the fact that our clinical lead for the study had an unanticipated commitment to the military and had to leave right at the beginning. So we're very happy we're in the recruiting stage. This is just an IRB approved recruitment flyer that we're using for the area in South Florida. We're also using it in conjunction with some social media channels, again, specific to regionally targeted in South Florida. So I have learned a lot from this collaboration. I want to impart 3 of those lessons with you. The first one is just the real impact of involving someone with the patient perspective on the front end, at the very beginning, before you write the grant proposal, before you write the IRB, before you go through any of those processes, but specifically with the IRB and the informed consent. So for those of you who are not familiar, the IRB, the Institutional Review Board, is comprised of a group of different members, but sort of the requisite member that has to be there is a non-scientific person who is typically a member of the lay public. So as you can perhaps imagine, if you have a group of researchers getting together, or research clinicians getting together and designing something and writing up the informed consent and writing all this language, once it gets to that point, that might be the first time that an actual patient or an actual member of the lay public sees this information. So having, in this case, Dana involved from the beginning was very helpful. It was somewhat jarring to me to find out how poorly I was writing informed consent forms. but the end product means it was vastly improved over what it would have been. The other thing is sometimes when you get immersed in research, when you're immersed in the process and the paperwork, et cetera, you can erroneously think of the folks that are volunteering as being research subjects, sometimes because the paperwork you're filling out refers to them as research subjects. But of course they're not. These are people that are taking their own time, volunteering their own time, committing their own resources to participate in research that may or may not directly benefit them in the immediate term. So these are definitely research participants, not research subjects. And I don't think Dana's let me call them research subjects for a while, so that's good as well. So the final one is that this type of, some of the technology that we're using in the study has real potential to reduce clinician and patient burden. And that could be time, that could be energy. Kim Petty, I think, was yesterday talking about the fact that if you want to change processes or get new initiatives adopted, et cetera, in healthcare, the very top thing on your list is you have to take something off their plate, reduce some sort of level of work for them, example. So I think a couple of the things that we're doing here offers that. So we can get that buy-in, so we can get it adopted and get it implemented, and so it's done in a sustainable way. All right, at this point, I am going to hand it off to Dana.
Thanks, Kevin. So I want to ask a question first, and I can kind of see you guys, but everybody here is patients, whether you identify as an e-patient or not, but who has participated as a patient in a clinical research trial? Wow, okay, more than I expected. So I'll just tell you my experience with clinical trials up until this point was very low. I think I've participated in 1 or 2 as a patient. Wasn't very excited about it because there's not a lot of clinical trials for me, about me, would help me. One, because I have type 1 diabetes. I was a youth. I lived in a place that didn't have a lot of research going on. I lived in Huntsville, Alabama. I did have a doctor. We do wear shoes down there. But I was not part of a major medical or academic research center. So I went to the doctor. I was healthy, got checked up, but I wasn't in a place where my doctor would pull me in or ask me or invite me to participate in research. So to be honest, I was really cynical about what the process is, how patients are treated when they go through this. Like Kevin said, we volunteer our time. We're really trying to invest in the future, do something we can other than day-to-day care. It's kind of saying, okay, maybe I'm not a doctor or a research scientist who's doing stem cell research or whatever kind of research will hopefully bring us a cure, but this is something I can do to help us get there. So I was very cynical, other than that little bit of altruistic, okay, maybe that'll help us with a cure, until Kevin approached me. And again, I was cynical, saying, well, this is about type 2 diabetes. Is my perspective really valuable? I'm not a research scientist. I haven't participated on research on this side either. I don't know how to design a clinical trial. What is my role in this? So I was a little bit skeptical in that regard. And I just want to share, some of you guys heard my patient story yesterday. These are just some snapshots from TwitPics of my patient experience. So if you follow me on Twitter, TwitPic, you'll see pictures of my pump and my meter, me drinking juicy juice in really random places. But to me, that's what life with type 1 diabetes is. And I've learned a lot from being able to engage with providers online and members of the health community online to figure out what are the barriers, why are patients labeled by their disease? Why are we addressed in such ways? How can we work together to better improve healthcare? So as a result of that, as a result of being involved in HICSA, meeting great providers like you guys, I decided that if we expect providers to change the way they're doing things, I should be able to change my mindset and participate in this trial and see how it goes. So I just decided to give it a stab in my free time. So just so you know, I do HICSA. I also work for Swedish. That's my employer, my disclaimer. But this is something I do in my free time. So when I was approached to participate, like I said, I was very, very, very cynical. For one reason, because I'm so used to hearing us labeled by our disease. So for now, if you're calling people diabetics, please stop. I am not a disease, I am a person. And it's one thing for a person to label themselves, it's another for you to blanket label people as their disease. It's very disheartening to hear me thought of in that regard, because for one, if you think about a disease, yes, you can give me insulin, you can tell me to test my blood sugar, eat right, exercise, but I can't control the stress on my body. I can't control how my body is reacting when I get on stage. Is my blood sugar gonna just jump up out of nowhere? Possibly, or it might drop. I can't control that. And so I can control what I'm called, and so I prefer not to be called by the disease, and a lot of patients feel the same way, whether it's diabetes, cancer, asthma, a bunch of other things. So one of my first contributions, I think, was really talking with Kevin about how patients are referred to as participants versus subjects, and also by the disease. And one of the reasons we chose to name the study, like he said, after adherence rather than compliance is because compliance, again, is me doing what you tell me to do. And like you said, I'm, self-assured? So I like telling people what to do. I don't like people telling me what to do. So compliance is one of those words where the doctor tells me what to do, and if I don't do it, either because it's a really silly idea, it doesn't work for me, or it just, whatever reason I forgot, I'm labeled as non-compliant. And so there's a whole host of issues wrapped up into that. So really thinking about the language in how we refer to patients as people, as participants who are helping advance this clinical trial is really important. So we really looked at language, but one of the biggest one was not referring to people as non-compliant diabetics. Ugh, ick. Anyways, so like Kevin said, one of the biggest things I did was really look at the language for everything. I did go through the normal city research thing to make sure I was legally able to participate in this and review the paperwork, but I looked at the informed consent form. The first thing I did was put about 18 notes in the comments that said, what does this mean? What does this mean? Did you mean this? Did you mean this? And the perspective is, for somebody who's not involved with research, the patients who will participate in the study will do the same thing. They'll wonder, did you mean this or did you mean that? How are you going to use my data? Do I really need to come in this much? Can I just send it in? There's all these questions that come and can be answered up front by really being articulate and detailed in how you fill out this form. So kind of the lesson here is that the little details do make a big difference, and like Kevin said, involving a patient up front, getting somebody with layperson eyeballs who's not used to this language, it makes a big difference in terms of getting that stuff approved and then not having to answer a million questions later. I do want to say, like I said, I was very cynical, but having gone through this process, I'm pleasantly surprised with what a great experience it was. I will say, I don't know if Kevin is the typical researcher. He was really great researcher. He was really great to work with. He was very clear about what value I was bringing to this process, what my role was. When I had questions, I was very comfortable to work with him. Had it been somebody that I was less familiar with or wasn't as good of a communicator, it might have been a different process. But that being said, I think the fact that we're here talking about this means the future for this kind of participatory design approach is really positive. And so I'm excited to see more patients involved. But like Kevin said, he picked me because I was self-assured / bossy / whatever you want to call me. But that doesn't mean that you have to know the patient really well. I think it's a matter of coaching the patient. So asking those questions, are you comfortable speaking up for yourself? Are you comfortable sharing your story and reviewing this material? And it doesn't have to be publicly necessary. You can also give their feedback in a private, offline, phone conversation method, whatever that is. But I think it's really important to help coach patients and not just either assume that they know what to do, pick somebody who's self-assured, but really coach them and get them into that. Because the more patients we get involved, the better all these clinical trials and research projects are going to be. But I do think it bodes really well that we have folks like Kevin starting to do this more and more, and some of you may be doing this as well. But again, the elephant in the room is the patient. I'm a patient, but I was not taught to be a patient. Similarly, I was not taught by going to the doctor how to participate in this process. So coaching is very, very key. Defining the roles, explaining what the value is, convincing them to participate. Remember, I'm a patient. I have a totally different career. It happens to be in healthcare. A lot of patients don't choose to work in healthcare. They're not as familiar with what IRB means, what it means to have to go through this review process. What is the timeline? What is the time commitment? So explaining and detailing all of these things is really important. But just remember, if you get tired of doing that, you're going to have to explain this to your patients anyways. You're going to have to write this up in materials anyways. So just consider it practice for how you're going to write it down for your informed consent form and explain your research study to a room full of people, a room full of patients who are going to potentially participate. And again, we're new to this. So the lessons that I have learned from this process is that patients do have a role on this side of clinical trials. It's not necessarily always being the lab rats, which is sometimes what patients feel like we're always being tested on. It's very empowering to have this role, but realizing it is different. My role is not the same as Kevin's, it's not the same as Boris's, so I have to kind of respect those boundaries, and again, it's a conversation about those roles. But also for patients, or anybody who participates in this manner as a patient, don't let yourself be inhibited from fully participating. Don't be afraid to speak up and say, patients are not going to go for this. This is not right. This is insulting language. This is not going to work. Or on the flip side, this is great. I think this is going to work really well. Something else I didn't mention that I participated a lot in was looking at what do the text messages say for some of the arms. So making sure the text, when they come across, whether you're interrupting something or you're out to eat or you're at home taking your medication when the text message comes through, making sure those text messages are as generic and appropriate as possible for all those different situations, but making sure they're not offensive or they wouldn't really contrast with the vibe that we want to give off through the study for patients participating. But again, I think having patients participate and speak up and really not be afraid to participate in this process is really key. And so in that regard, I'll hand it over to Boris to talk a little bit more about the technology side of this.
Thank you, Dana. So my name is Boris Glance. I'm the co-founder and CTO of mHealth. I'm really thankful to be at MedicineX because listening to talks about big data and 23andMe about all the things that we can do with genetic testing make me realize that we're actually all trying to solve the same problem, which is how do we create more transparency in the medical field and how do we empower the patient to be in control of their own outcomes. And Tonic for Health was born to solve the same problem. How many of you have been to a doctor's office and filled out a patient intake form? It's the most ubiquitous experience we all have. How many of you enjoyed the process? There's one hand. How many of you smiled when you were filling out a patient intake form? Out of sarcasm, that's exactly it. So when we were looking to transform that experience, we wanted to understand what were all the things that were making us cringe, and we wanted to transform that experience to actually make people smile so we could collect more data, so that data could be used in risk assessments or provide you education at the point of care and actually be used to solve problems for you immediately, whether it just be an experience that you're trying to scribble down as fast as you can so a doctor can see you for 7 minutes. Because ultimately, when you look at that paper, you notice that there's like almost a competition between the doctors. How many questions can we fit on one page? And the more questions we can fit on the page, the better it is. Well, it's better for the doctor because they look at it and they can see everything right there. But is that the best way to collect the data for the patient? And oftentimes there's that disconnect that happens. So we wanted to solve that problem. Now, how do we get involved in the Remind study? Kevin was generous enough to reach out to us because of the work that he heard that we did with the Athena Breast Health Network. And it was primarily about a longitudinal study. How do we get people to come back and fill out the same boring forms and make it fun? So that was the first point that we wanted to help them solve. The second part was, how do we make the actual process more simple for the researchers? And there were components to this research that Kevin was mentioning that involved cognitive exercises. For instance, asking people to name as many animals as you can in the next 60 seconds. Or join a clocks exercise that says 1 hour and 45, and you can't say 1:45, you actually have to draw the old-fashioned clock. And those things required a proctor to stand there and do an evaluation. And if you want to do a study that involves many patients, you need to hire many proctors, and you need to train them, and you need to make sure that they're all actually scoring those things consistently, because none of this is being recorded. What if a person misheard an animal and didn't give them a point for that? So all of those things are impacting this study. So what we could do is we could record all of this on the iPad. We could do a recording of a person saying the animals over the next 60 seconds. We could draw the clock on the iPad and send all of this to the cloud for analytics and analysis later on, to create consistency, to create transparency, and actually improve accuracy. And the final part was about that, to enable researchers to analyze this, because there's 3 groups that needed to be compared. I want to talk a little bit more about the first point, which I made, is about engaging patients and transforming the clipboard experience. Over the past year, since Tonic has been founded, and all the work that we've been doing with various different clients, like Mayo Clinic, UCLA, really made us rethink the way that the patient wants to enter data. And one of the first discoveries that we made is that pairing the questions with contextually relevant graphics completely changes the level of engagement. The first thing that we see is when we look at this question, for instance, is there is a silhouette of a man and a woman, and automatically that gives us a sense like, oh, is this about gender? I haven't even read the question, but I'm already understanding what the context of it is. The other thing that happens is if you rotate the pictures and you put a different picture on each screen, the patients smile and they want to see what picture you're going to serve up next. So they want to click the next button. And when was the last time somebody wanted to see and fill out a form in the patient waiting room? The other discovery that we made is actually removing all the clutter from one page and enabling the patient to just ask one question on one page created a sense of focus. They could only be focusing on this question and not looking around and not skipping around. And finally, to increase the actual speed, we change all the questions to use to provide the answer choices. It's like, remember the times that we were in high school and we were all taking tests? How many of you preferred the multiple choice test to an essay? It was easier to take, it was easier to grade, and you got out of there faster. So instead of asking somebody, what is your occupation, and leaving a blank field, we can pre-populate some of those things and account for 80 or 90% of the patients. You could do this for most of the questions. What are the medical history that you had? What are the types of drugs that you're taking? So that speeds up the whole process and the perceived process. And the other part is adding skip logic to it, not putting things on the form that says, if you answered this question this way, go to page 2, section 3B. You just do this all automatically, and the patient just sees all the questions that are relevant to them. So what does this mean? We all heard the adage that a picture is worth 1,000 words. Well, from our experience in our tests, it turns out that our pictures are worth 40% more data. Because in a sitting, we can collect 40% more information without increasing patient fatigue. And that translates to more data to be analyzed and more insights that can be extracted for research. Now, working with Kevin and working with Dana has been incredibly interesting. The first thing that I remember realizing is that we're constantly working on improving the tool. And we've tested this with lower income people, lower education, Hispanics, elderly. And we think that we're constantly improving the tool, but every time we go into a new study, there are always new things that we uncover on how to make it even better. And that's the part that really gets me excited. Because collaborating with folks like Kevin, who are really in the forefront of mobile health research in academia, enables us to expand our platform to provide better care for patients. That recording question that I told you about, it's right there with a little microphone, and that drawing question that's in the bottom left, those were pushed and created because of the research demands that Kevin had. But they could be reapplied. So for instance, now we can have patients, elderly patients, who are taking the iPad home, and they can be given the clocks exercise or recording exercise that they could do at home that could be sent immediately to them and be analyzed. So it constantly pushes the envelope for us. And what I'm really looking forward to in this space and seeing this evolve is doing more of this type of research that enables us to better leverage technology to really improve patient outcomes. And I'm talking about risk assessment or patient education, things that we can embed in that experience. Thank you.
So I kind of wanted to close with the fact that I think all three of us would agree we each learned quite a bit during this experience, and we think there's a lot of positives that have come out of this. For instance, with this particular study, it's been constructed in a way and it's been tailored in such a manner that it's going to be a much stronger sort of final product, as it were, than if we'd try to create it in silos, which unfortunately too often happens. Because of this, we're suggesting that this is one way that can be used to help improve patient outcomes. There's been a lot of conversations about engaging patients and providers regarding clinical care, which there should be, but if we're looking at some level or some degree of research that drives change, that drives practical changes in guidelines, in practice, et cetera, then we would assert that if perhaps there was more of these elements integrated at the front end, that the final, what you get out at the end, is similarly going to be much improved as well. So I just wanted to acknowledge and thank the rest of the Remind study team at Nova Southeastern University. They've also worked very hard on this as well. And we'll close with this, our contact information, and I'll join my fellow team members, and we'll be happy to try to answer any questions that you may have at this time. Thank you. All right, so if there's any questions, I'm getting a little bit better on the lights. I'll take a look with an eye towards the mics for any questions for the panelists.
And if there's not any, oh, there's one.
Hi, Patty Clark from University of Michigan. Dana, what did you find the very most challenging thing about being a participant?
So the most challenging thing as a participant was really understanding who all these people were who I've never met. Actually had not met Kevin in person until Friday. So getting to know the researchers through email and phone calls was a little bit of a challenge. And then again, understanding all the rules and the processes, because it's going to be different for every single trial. So although I know the basic timeline and process, understanding exactly what the timeline was for this, what happened when our lead researcher left, staying in communication with that was, I think, my biggest challenge.
And just one quick follow-up. Is there some piece of advice that you would give to other patients?
Yeah, I think it would be, don't be afraid to ask questions. Ask if you don't understand. The only dumb question is the one that you're afraid to ask. And I think that's really true as a patient when you're talking with your doctor, but also true in participating in this process. So don't be afraid to ask questions. Don't be afraid to ask a researcher and say, hey, do you have a patient involved in your research? Would you like to involve me up front? There's a lot of patients here and around the world who want to get more involved, and I think this is a great way to leverage patients in redesigning the trials, hopefully the outcomes, and then improving care that way.
I think we've got someone up front.
Yes, Cisco. I'm a health services researcher from Toronto General Hospital. I have a question for you. What was the institutional response, Kevin, when you told them you wanted to involve any patient? And do you see your colleagues as saying, yay, we're going to do this, or more like, you're the black sheep?
Thank you for the question. Maybe I was the gray sheep. So it wasn't, I think it was somewhere in between the celebratory mood and complete lack of desire to see it happen. So I think the folks that have been involved in clinical research for a while appreciated the perspective. Definitely the folks on the team, once they saw what was brought to the table by adding Dana to it, were very happy with it. And in terms of institutionally, I think our IRB is relatively progressive, maybe because we've already run some mHealth studies and some other things. They're used to seeing some aspects that others maybe have not. So overall, maybe sort of a cautious optimism by some of the members. Did you have a question?
I guess my question would be, for what advice would you give for research in terms of identifying or selecting a patient, or how to identify what assets and skills you think a patient needs to participate in more detail?
I think one of the things that a researcher can do is be involved in social media, ironically. So for me, Twitter is actually one of the most useful professional tools that I have. I've found out about grants through Twitter. I've met fellow researchers that we've gone on to do work with. I do have a couple of different cases like with you where I worked with something and maybe even took it all the way through publication and then didn't meet them until afterwards at a conference in some cases. But I think if you can target the kind of search that you need, use some of the tools like social media, use some of the other things that are coming up. I think there's some interesting things in the pipeline with clinicaltrials.org, et cetera, that are being done with trying to identify patients. Those are some tools that you could sort of avail yourself of and try to incorporate that piece in.
Mm-hmm.
Other questions from the audience? So,
There's a question over here.
Oh, yes, ma'am.
Yes.
What are your development plans?
What are our development plans? So basically, one of the interesting things is because engagement is really about serving up various different content and making it more appealing for patients, we obviously can't draw many pictures ourselves. So we want to open up the platform for other designers to come in and come up with more engaging questions. We have A/B testing analytics that can then test out and figure out which questions and which designs are most optimized for asking a particular set of questions. And that way we can get more specific ways of capturing data and find out what is the best way to do so. So that's the future expansion. The other things that we're working on and doing is risk assessments. So for instance, we're talking about like using a Tyrer-Cuzick model, Gale's model for breast health research, just basically cognitive tests. For instance, we're working on a deployment at UCLA, and they're screening patients for depression. So screening and risk assessment that is happening in real time in the waiting room. How does that translate to better care on the spot? That's another piece that we're expanding into. And I would say the final piece is, again, the patient education component, which is how much time can I save the doctor by actually providing relevant content to the patient, again, in that waiting room before they see them, and then let the doctor know what information I, as the patient, have seen. They spent about 3 minutes or 4 minutes looking at this particular video. Now I know that they're aware of this type of stuff. So how does that impact our encounter, our 7-minute encounter when we actually get to that doctor office? So those are the 3 areas that we're looking to expand.
And just one other question or comment. Do any of you think that the need to simplify, to use images and all that could backfire and contribute to the idea that patients aren't able to access information unless it's been dumbed down?
I could take that. So I think that is a cautionary tale. So in the sense that we've done a lot of research to figure that out and make sure that that doesn't happen. We do the printouts and the reports and the basically PHR that we provide for the patient doesn't have the graphics. It's really about the data collection. And I think the other component that's very important to mention is what we're all trying to solve with using technology is not to ask a patient the same question over and over again. So if we maintain their medical record, I don't need to ask you the same information 10 million times. I'm just going to collect it once. It's stored for you. And I think that's the vision, and that's what we're heading towards at Tonic and in other companies like EMRs that are working on this. That will reduce the fatigue, and I think that will not give the sense that we're dumbing down the question. We're just trying to bring a smile to somebody's face, and that's it.
And I'll add, I had a little bit of hesitation when I heard about Tonic. I hadn't heard of you guys before, but it's really more about the user design experience. So what is the design that makes it easy for me to give this information in a less abhorrent way than filling out a million forms? I had a twit pic in one of my other presentations, and it was asking me to fill out what problems do I have. Listed heart problems, respiratory problems, and diabetes. And I wrote on my form, diabetes, parentheses, is not a problem, it's a chronic disease. So it's really about the user design experience of how patients are able to get that information really quickly. And I don't feel like the pictures, in my experience and looking at this, had a negative effect. I was really appreciative that somebody thought about the design and helping me process and get that information out as quick as possible.
I didn't mean on the patient, I meant on society, saying that, hey, there's all this new companies, they have to make things simple for patients, they can't do it like us, the professionals.
I would, if I may, I would assert that's not what's happening in terms of it's not dumbing down, we're not lowering the bar. I think if you look at Medicine X, for example, in terms of the presentations, you've got a lot of clever and brilliant folks put together here. And if you look at a lot of the presentations that they're giving, they're using contextual, graphically tied pieces to the data or their information in order to share it. And that's because the research has demonstrated that by doing so, you're lowering the cognitive load, you're making it easier and enhancing understanding, comprehension, and retention. So it's really sort of building on a little bit from that area of the neurocognition in taking this type of approach. But I think your question is really interesting because there will continue to be challenges. So we're in South Florida. We have an incredibly diverse patient population. One of the other projects that we're looking at, for example, with a diabetes clinic, has almost exclusively patients who speak Haitian Creole and have come from Haiti. So in terms of sort of contextual issues there, culturally appropriate types of information, and even in some cases, the graphic pieces, those are going to be different or can be different between different groups. So it's something to definitely remain cognizant of, which is why I like the question. But I don't think it's in any way suggesting that we're dumbing down things. I think, if anything, we're trying to take advantage of science and leverage what we know about how people perceive, comprehend, and retain things.
I think we had a patient question.
So this is actually a question from Twitter. Dana, it's clear you don't like the word diabetic, so what would you prefer?
Person, patient with diabetes, Dana. You know, it's okay to call me by my name. I don't have a fancy title that people get confused about. You can just call me by my name. But that's, again, the idea of Kevin talked about using the word participant. Patients are participating. We are people. So thinking about us in the context of our lives and what do we have to give up, because there's opportunity cost in everything we do. I take time away from my family, my volunteer work, my full-time work in order to participate in something like this on this side or as a regular patient participant. So being thoughtful about how we engage with people, whether you're talking doctor to patient, to a room full of patients, or in the case of this study, I think it's really, and I think this has been reflected in the Twitter conversation throughout this, is really being thoughtful about how we communicate with people, being respectful to patients, to providers, to everybody we talk with. I think it's worth thinking about in every level of healthcare.
Hi, I'm Lisa Bernstein, and I'm not cancer. I've had cancer 3 times. I'm an e-patient here, and this is more of a comment than a question. Really interesting work that you're doing. My experience with breast cancer in the last 18 years is I would go every single year, several times a year, for a mammogram to the same, very highly regarded center in Los Angeles. Every single time, new forms to fill out. And in and of itself, the forms are, as we all know, we hate them, they're a pain in the neck, but there's another dimension, which is there's a kind of a PTSD trigger thing that happens. Every single time you're filling out this form, you are revisiting and telling, it's like, you people should know this. I have already filled this out a bazillion times, et cetera, et cetera, et cetera. So that emotional trigger aspect, I'm sure it's not something that I am alone in having experienced, and I think an approach such as this, especially when you bring in someone like Dana or an e-patient, it gets you thinking about not only answering the questions that might be necessary for the doctors to know, but how can we improve that whole process for the patient and maybe take into account some of those other things, because at the end of the day, you want patients coming back for these tests, because when you get diagnosed with cancer at age 29, the mantra is, oh, you're so young and we're going to be so vigilant about you, which is great. That's how I discovered the other ones. But at the same time, you are now living the whole rest of your life with this pain in the butt, to be polite, and to understate the impact of it on you emotionally. So anyway, that's my comment. Thank you.
Thank you for your comment. I completely concur, and I think something we haven't talked about in depth this year so much, I've seen it reflected online a little bit, is about the need to discuss interoperability of data. So how does your form interact with my electronic medical record? Can I see that I've taken these surveys or participated in this research through my patient portal? I think looking at all of this and then being able to retain it for the next visit, the next trial, if possible, is something that I'm looking forward to seeing evolve in healthcare.
Absolutely, we're looking to address that problem. I mean, we really believe in interoperability and work with EMRs. We use HL7 or CCDs, Blue Button Initiative, we're working with that. All of those things to get you the record, Health Vault, everything.
Yeah.
So thank you very much for your questions, and your time and your attention. We're at the end of our time. So thank you.
Thank you.
Thank you.